What we do is truly a patient-centered dispensing, patient-centered practice.
What's critical is that pharmacists themselves accept that's what they are.
Do not call it a retail pharmacy.
Yeah.
Because we want to shift the narrative of what a retail pharmacy is.
I am not a pill pusher. We don't push pills. We de-prescribe.
Oh, yeah? Okay, I guess we already started, but let me do the introduction. Welcome to RxRevolution. We're happy to have Dr. Arouchanova and Dr. Svadjian here. We're going to talk about community pharmacy. We're going to keep this conversation pretty cool, even keel. Let's start off with the basics of the basics. What is community pharmacy?
Okay. I guess I could take that one. And
Sure.
sure.
Yeah, and I can add.
I think, first of all, it's unfortunate that a lot of people don't call it community pharmacy. Mm-hmm. They'll say retail or chain, etc. But I think practitioners like Diana and myself, we like to refer to it as community pharmacy. And to me, whether it's an independent pharmacy or a chain pharmacy, I think it's a community pharmacist is someone, or a community pharmacy is a place where the local community can go to get healthcare. It is the most accessible healthcare outlet for patients. And that's what a true definition of a community pharmacy is. I think a lot of times what people associate with pharmacy is that it's a commodity, right? Mm-hmm. I just go to the chain drugstore, I go to CVS, and they take care of it. I get my prescriptions and
maybe I can buy some shampoo.
Exactly, and that's what the expectation is when people say, "I'm going to the drugstore, I'm going to the pharmacy, I'm going to the pharmacy." But I think a community pharmacy is somewhere where people gather in a lot of smaller rural communities. In the old days when they had soda fountains and things like that. But I think the true definition of a community pharmacy is somewhere where people get healthcare and get information about their well-being. Not only if they are on meds, but information that the pharmacist can share with them. To me, it's a destination for healthcare. That's the way I like to look at it.
I like that you said that. I mean, the first class for PPP, the thing that they taught us straight out the bat was do not call it a retail pharmacy.
Yeah.
Because we want to shift the narrative of what a retail pharmacy is to a community pharmacy, because this keeps popping up all the time. I don't think that the broader community or the population at large really understands the scope of a pharmacist in a community pharmacy and all the things that they can, actually do to help you. So destination. What did you say? Destination?
It's a destination for healthcare. In fact, the pharmacy we're building in South Los Angeles, the Mann School of Pharmacy is building a new pharmacy that's going to be in the heart of South Los Angeles, where there isn't a lot of healthcare accessibility for patients. We're looking at it as a destination for them to come there. We're going to have clinic rooms in there. Diana can talk more about that. She's been a pioneer in that world. But we're going to have clinic rooms in there. We're going to have a room for healthcare education for the local patients as well. So that is the true definition of a community pharmacy.
Agreed.
So I 100% agree with what Raffi just said. Community pharmacy, the definition of community pharmacy somewhat was lost. And I think it's very important that when I talk about my practice site, I always make sure that I describe it as a community-based pharmacy practice site. So a lot of times people call it a retail pharmacy because, first of all, there is no such concept as a retail pharmacy. Every pharmacy in state of California, and maybe outside of the state too, which I'm not familiar with, but I am familiar with state of California, is licensed as a retail pharmacy.
Okay.
So I think that's probably where the term originated from. Yeah. I'm not sure, but using retail when it comes to pharmacy is such a misinformation or misconception.
Absolutely.
There's nothing retail about the pharmacy unless you're looking at big box chains like CVS, Walgreens, and I'm not even going to go that route because I'm not a big fan of those places. We're teaching the next generation of the pharmacists. I think they all need to do what I'm doing, and that's just going to be the most wonderful thing that's going to happen to my profession. And I'm just going to retire and just take the deep sigh. Right?
And that's community pharmacy.
That is community pharmacy. So community-based pharmacy practice site is truly where people, like Raffi said, where people gather and they can stop by at any time and talk to their pharmacist. So what I usually talk, when I usually talk about community pharmacy, whether I'm talking to you, my students, or residents, or my community, I always tell them This is where you can come and talk pretty much about anything and everything. And it does happen on a daily basis at my practice site. Also, a lot of times what people misinterpret about community pharmacy is that they think this is the place where you walk in, like in old times, you hand the script over to the person behind the counter, and then in a few minutes, something in a bottle comes back to you. That is not the practice of community pharmacy. That's dispensary, which I don't think does not exist. What we do is truly a patient-centered dispensing, patient-centered practice. And we provide enormous amount of information to all the patients going in and out of the pharmacy. And in today's community pharmacy market, I guess, we also provide a lot of disease state type of services. My practice site is one of them, with exam rooms where patients actually can come in, be examined, assessed, and receive many other services in addition to getting their medications.
That's interesting. Can you expand on like the disease state and like what kind of patients do you see with that? And
specifically, I practice in primary care. So I consider myself a primary care pharmacist. Okay, that's a term that I love using. And I'm really hoping that more and more students, pharmacists, newly grads, people who graduated a while back will also start using, if they're practicing in community-based settings where they are actually providing services for hypertension, diabetes, hyperlipidemia. Those are the things that I do. There are a lot of other disease states that pharmacists can practice in. There are a lot of pharmacists who practice in oncology settings. There are pharmacists who practice in psychiatry. There are so many areas of the pharmacy practice that exist. My specialty is primary care, which is diabetes, hypertension, chronic heart failure, hyperlipidemia, lung diseases. That's what we do. So people who come in to us already have those conditions diagnosed by their either primary care physician or specialist. What we do is we become part of their healthcare team, and we help the physicians manage these patients better because we're the experts in the medications.
That makes sense. And that's such a vital role. And I don't know that people really understand that a pharmacist, I think they see the pharmacist and they're just like, okay, give you the script. Okay, you're giving me my drugs back. Not the fact that you guys can actually walk up to your pharmacist in your local pharmacy, ask them questions, say, hey, this medication was making me feel X, Y, and Z, what could be the cause? And they can actually help you troubleshoot all of your problems and maybe even connect with your provider to see what other medications would be best for you in that scenario. Dr. Svadjian, correct me if I'm wrong. You work in a community pharmacy?
Yeah, so I manage 3 community pharmacies for USC, as well as help the specialty pharmacy here at USC.
And so what are some important tasks that you do maybe all the time, sometime in your pharmacy that the population doesn't really know or the community is not aware of?
So that's a great question. I mean, in my role right now, I'm more of an administrative function, managing the finances, managing the operations, and doing things like that. But I can tell you, when I was a pharmacist, some of the tasks that we do that are not traditional and people wouldn't know if they hadn't sort of looked into it further. We have clinics in all our locations. They provide travel medicine services. They provide some disease management, like Diana just described. They help with smoking cessation for our USC community patients. They counsel on every prescription, which is required by law, but the counseling doesn't necessarily have to be shallow. It gets deeper into it and talks about the person's disease state. We provide meds to beds programs where we're adjacent to hospitals, so we're providing medications to the patients.
Oh, wow.
We have a specialty group that just handles transplant patients. So every solid organ transplant patient that leaves from USC facilities, we manage their medications for them. We provide compounding services, which studied with Dr. Arouchanova. So those are a lot of the things that people don't see on the surface when you just look at the picture of the pharmacy, but there's a lot of other things that we do beyond just giving the medications, right? I think one of the key things that there was a survey done a few years ago, and it said, what do patients seek the most from their pharmacist? And overwhelmingly, the biggest one was education. I mean, I know it because every party I go to, when someone finds out I'm a pharmacist, they ask me about the drugs that they're taking and what drugs I can get for them.
Oh my God.
You can strike that from the record. No, but my point is this, is that patients, there is a very big source for information called the internet, but nothing can ever replace that sort of guidance and information that the pharmacist can provide the patient. And obviously that's why you've come to pharmacy school, because you want to gain that knowledge and be able to share that information. So I think the number one thing we do, and I'm going to keep saying it, is making sure that our patients are educated, not only on the medications that they're taking, but about ways to live a healthier lifestyle and more well-being for themselves. So those are the kinds of things that we do at the USC pharmacies. We additionally have programs that help with hormonal contraception. We have 2 vending machines on the University Park campus to provide medications for students.
I've heard,
after hours. So we're trying to expand the reach as much as possible to make sure all of our patients at USC and general patients that come to us are getting service.
That's awesome. You guys have been working for a long time. You guys have a wealth of real life experiences. We were talking about medication management and patient counseling. Do you guys have any real life scenarios where you guys were doing medication management and patient counseling and it like flipped the switch in the patient that you were speaking to and like altered their life in a way that was meaningful and positive?
I'll share this very interesting, very unique patient care case. I wasn't on duty. I was on administrative duty that day, and I overheard a couple of my pharmacists, and interns running around and discussing a patient, and they really wanted to help the patient who walked into the pharmacy. So I got out of the office because I wanted to know what was going on. And the patient walked in with 2 Trader Joe's paper bag size of bottles.
No.
She was in a wheelchair, and the daughter was wheeling her in, and then they were holding 2 full bags of Trader Joe's paper bags. So they started taking the bottles out, and that's when everyone, got kind of scared in a way, because the patient was there and, they needed help. Patient wasn't our patient at that time. Needless to say, she and her family and everybody else became patients later, but they were, it was a recent discharge from a nearby hospital where we practice. So of course I joined in the conversation, and as we started going through the bottles, I realized that there are so many duplicate therapies, and there were some medications which I suspected were given to the patient because of the side effects of the previously prescribed medications. So the bottles were not from the bottles were actually from one of the local chain pharmacies, and she wanted to transfer over to get more personalized one-on-one care with her pharmacist. So before we transferred the medications, I said, we're not transferring anything because my job is to de-prescribe. I love using that term a lot in practice because I am not a pill pusher. We don't push pills, we de-prescribe. But that's what my vision of pharmacy practice is, right? Because a lot of things can be done with lifestyle modifications and the proper use of medications.
Yes.
So instead of transferring, I picked up the phone. It was a lunch hour, called the doctor's office, and they were out to lunch. I left a message. I said, this is very important. You're the primary care. I really need to get in touch with you because you have a patient who was discharged from the hospital. Primary care called, said, okay, well, why don't we just re-prescribe everything that hospital gave her, and then in a month, I'll see her.
No.
I said, no, absolutely not. You are not going to see this patient for a month. I am looking at 3 heart medications doing the same thing. This is just a mess.
Happens every
so
day.
I said, if you have time, I actually will come with the patient to your office with their bags of medications.
Oh.
So it's an interesting story. Later, we became very close friends with this prescriber. She said, well, I am actually going to be having lunch close by at one of the restaurants where you guys are located. So I'll stop by at the pharmacy. And she did, actually. She stopped by. So within a couple of hours, we went from 28 medications to about 8 medications.
Wow.
We've changed everything. I scheduled appointments weekly with this patient. The daughter would bring her in. We would manage things. We would change things. We would modify things. And the patient was out of her wheelchair within a couple of weeks. Her wheelchair situation was because of her swelling in her feet, which was caused by one of her medications. So long story short, this is a prime example that, you can't fix problems with just, giving people pills, but you just need to know what to prescribe to them, how they're supposed to take it. And a lot of times people will just say, I don't need a consultation. My doctor told me how to take it. Well, no, not really, because as a patient myself and as a healthcare provider who works with hundreds of doctors under our collaborative practice agreements, I know that a lot of times primary care doctors, all they get is 5-10 minutes with the patients in the room. So in those 5-10 minutes, they really need to squeeze in all the assessment and make sure that, all the, assessments are done correctly. And then the last 3 seconds is, here's your medication list.
They're not telling you how to take it.
They're not telling you
most of the time, at least.
Most of the time how to take it. So that's where we come into play. And in my case, a lot of times when people come, I remember when I first founded Clinic Care, I was the only person there, just, greeting people, doing everything A to Z. And I'm still doing that sort of, even though I have 15 employees. But I remember this one time when the patient walked in and handed me the prescription, I looked at it and I said, I can't fill this. I have to call your doctor. She looked at me and she said, why? I said, because it's interacting with your XYZ medication. She said, you didn't even look in the computer. How do you know something is interacting? I said, because I know what you're taking, and this is interacting with all of your medications. So talking to the pharmacist is very, very important. Very important. And talking to the right pharmacist is even more important.
And like the lady that came in that was in the wheelchair, I'm sure you said she came in because she wanted a more personalized experience with her pharmacist, and she got exactly what she wanted.
That's exactly what she got.
Yeah.
Maybe this is a good way to define what you asked earlier. What is a community pharmacy, right? So that's a great example of, and those situations, that story stands out in Diana's mind. I bet they happen at least a few times a day across the country.
Too often, yeah.
Absolutely. And that's why we always encourage patients, it's easy to go from one pharmacy to the other. And, years ago, like CVS and Walgreens would do coupon programs. So people would transfer their prescriptions. And they still do. But at the end of the day, if you have one central place where all the prescriptions are coming in, at least it allows us to do that, analysis of the drug interactions and see if there's opportunities to improve or to deprescribe, as Diana said. That only can happen in one central place, because a lot of times they're going to their cardiologist and their rheumatologist and their primary care, and Diana mentioned too, they're just writing prescriptions because they're just trying to cover that problem list at that moment in time for that patient. If all those prescriptions come into one place, I can't tell you how many times we found situations where there are opportunities to deprescribe, or the patient's taking Prilosec and Nexium because they have two different doctors that wrote it, and the patient doesn't know. They just continue to take them. So this explanation, this sort of stories that Diana is sharing is a great way to describe what a community pharmacy is, in my opinion.
No, yeah, you're absolutely right. Because this would be the reason why I would want to go to a community pharmacy, if I could get this one-to-one interaction with my pharmacist. And I'm sure my parents would probably stop calling me a million times a day, asking me what medication, how do I take my medication, kind of thing, if there was a network of doctors and healthcare providers that actually spoke to each other, because oftentimes I'm finding that I'm telling my parents, well, you spoke to your hematologist. Is your hematologist sending over those records to your primary care doctor? Are they talking
Melissa,
to each other?
are you saying you don't like talking to mom and dad every day?
I mean, come on. If I'm getting like 10 calls a day and I'm like, it can be a little harrowing.
Well, they're proud of you that you're going to pharmacy school. So they want to use
they
your education
know,
for
I
something.
know.
I still get calls from mom every day about her medication.
It's not going to end. So that's okay. As much as I'm going to ask for it to. Yeah, it is. It's fun now especially now that I'm like, okay, I can actually put the stuff that I'm learning to use. So like helping them counseling on the medication, or giving them the directive to, like my mom is on a thyroid medication that probably interacts with every drug that she's taking. Yeah. And so she has to take it at 3:00 in the morning because she has to space it out for the next medication that she's taking. And so, now she's doing her own research and she's like, oh, Melissa, this medication that I'm taking, I think it interacts with my thyroid medication. I said, Mom, call your doctor and tell her exactly what you told me. And lo and behold, she got her medication switched. So it's like, it's that instillment of confidence that they have the ability to actually take charge of their life. And
one of the very, very important things that I teach my patients, my community, that you have to become your own advocate. Like I empower patients the way I empower family members and my community to become their own advocate. So, so many times people will come into pharmacy and they'll be, prescribed medications. You go out to them, you tell them, we can't do this. You have to come tomorrow, or there is certain work that we need to do because we need to work with your doctors. There are a lot of patients who are seriously afraid of their physicians. They'll look at us and they'll be like, so wait, you're telling me you're going to call my doctor and you're going to tell my doctor that I'm not supposed to be on that medication, but he said I'm supposed to be on it. No, I'll take it. So then this is where the education component that Raffi mentioned comes in. Like, okay, sit down. We really need to explain this to you. Yes, the doctor prescribed it to you, and yes, it is an appropriate medication. However, it is not there is a better alternative for you because of XYZ. So when you empower them, when you educate them, and you make them into advocates for their own health, they actually
absolutely
do better.
Yes.
They actually don't sit there and, pop pills or not. And sometimes
they don't take
popping pills becomes a burden. So now adherence becomes an issue. People, because of that pill burden, no longer want to take their medications. So it's very important to really have that care coordination, which oftentimes doesn't exist, especially if patients have a specialist in one healthcare system, primary care in another healthcare system, and the pharmacy is a chain drugstore that has no connections or access to any of their records.
Yep. And it's crazy too, because like my dad has heart disease. So he has a hematologist, he has a cardiologist, he has a primary care doctor. He's seeing all these doctors, and I'm just like, your doctor is not asking about your other doctor's information, but they know that you're going to go to this other doctor, and they're actually referring you to tell your other doctor, but they're not talking. It's just weird that this huge disconnect
you know what?
exists.
I think that Diana brought up a good point earlier that, sometimes, a lot of times physicians, they get 5 to 10 minutes.
Yeah.
And sort of going through that whole list of things is difficult. I mean, I'll give you a great story. One day we got a prescription for a hepatitis C medications. At the time, hep C medications were roughly in the neighborhood of $28,000 or $30,000 a month supply.
Wow.
And in the clinical review, which still boggles my mind to this day how this happened, but they had written a prescription for a patient to take hepatitis C medications, which is a 3-month course, which is $90,000. And the pharmacist looked in the record, and the patient was never diagnosed with hepatitis C.
How does that happen?
I don't know. That's what I'm trying to find out, but it's been years. So I don't know how it happened. But needless to say, we immediately contacted the doctor and said, you're writing a hepatitis C medication for someone that doesn't have hepatitis C. Of course, we didn't dispense the medication and it all was good. But, back to that coordinated team, if at least there's someone that is that has the expertise, going to pharmacy school and so on, of looking at the medication history, I think there's a lot of situations like that could be avoided.
Yeah.
And I'm sure there's situations where that hep C medication, if it had gone to another pharmacy, that patient would have taken a 3-month course of hepatitis C medications.
And then what would have happened? You know what I mean?
Then you get the side effects and the drug interactions and, the unnecessary healthcare cost that is going to accumulate. To their insurance, and it's going to raise healthcare costs, et cetera, and the ball keeps rolling. I think a lot of people don't know that things like this do happen.
Yeah.
But I also know that a lot of people don't know that pharmacists and physicians and nurses, et cetera, but in a lot of these things get avoided organically, and nobody ever knows that they got avoided. Yeah. It's because people are doing the work that they're supposed to be doing.
Yeah, it's one of those things where it's like we're going to school for 4 years. We're the expert in all these things. But it's just like we're begging for you guys to use us. It's almost like, hi, pharmacist over here. Like, let us help you. Let us release that burden that you guys have to do this medication management so you guys don't have to, essentially.
Right.
So when I was in pharmacy school, I think I was first or second year. I don't remember exactly. I was at one of the EP rotations, and I remember a preceptor said something like, pharmacists are the most underutilized healthcare provider or professional. I went home and I thought about it a lot, because at that time I didn't understand why were we called so underutilized, right? So when I went to my 4th year rotations, and then throughout my 4 years in health systems, I was an intern at a health systems, pretty much rotating through every, setting of pharmacy practice, inpatient, outpatient, M-care clinics. I kind of realized why that statement was kind of out there. And he wasn't the only person who would say that. I heard that a lot. So that's when I was determined to change that, misconception that pharmacists are the most underutilized. No, pharmacists are not underutilized. Pharmacists are actually very well utilized. I have a physician friend who always says, choose your pharmacist as wisely as you choose your physician. And there's so much in that, phrase that, a lot of times people don't know. And it really doesn't cost anything asking and digging into things, as opposed to just, going with the flow. And the story that Raffi just described about the hepatitis C. So that's, That's something that's actually happening in community practice settings quite often because of electronic prescribing. So when e-prescribing initially started, everyone was talking about e-prescribing is going to reduce on the number of errors because of the scribbles on the prescriptions and everything. It actually did exactly the opposite. A lot of times, first of all, we know how to decipher and how to read the most horrible handwriting that's out there, right? I mean, a lot of times, my kids come and say, what does this say? I look at it and I tell them, they're like, well, we knew you would read this. But with e-prescribing, they can type 3 letters of the medication they intend to prescribe, and something e-prescribing is AI driven.
I didn't think of that.
It actually brings up something completely different. Next thing you know, that script comes through. Yesterday, we changed about 7 new prescriptions that came in that were not supposed to be what they were.
Wow.
We did it because we caught it because we know the patient, we know the patient's, history, right? But similarly, when people come to us, when Rite Aid was closing, and we were getting this influx of patients coming to us from Rite Aid, they were transferring their electronic records. And, you rely on the pharmacy because the pharmacy filled it as prescribed.
Yeah.
So because we talk, even though patients were on these medications, we don't just dispense it. There would be like, okay, we need to do history, we need to understand, we need to get to know you. A lot of the prescriptions that we actually transferred, there were medications that were not even supposed to be prescribed. And patients take them, like Raffi said, they take them because
they just
don't
think it's
know.
right. Yeah.
Yeah. We also check patients' electronic medical records, given, that our pharmacy also has ambulatory care department and we have access to EMRs. We're able to tap in and check all of that. But that kind of care doesn't exist everywhere.
No.
We're moving in that direction. Hopefully one day that care coordination will be
wonderful.
accessible to all. But for now, it is very important that your care is provided in one place so that at least one person can look at your medications.
That's true. And then, it creates a holistic view of the patient's entire history. So, and that connection with their providers will just essentially provide better care and a more positive experience, especially to those who might be nervous to talk to their healthcare provider or, scared of their healthcare provider. Talking about misconceptions and the experience that you guys both have working with patients and in the community, what are some misconceptions that patients had on their medications, or just rather in general?
About pharmacists or about medication?
About pharmacists, whatever.
Do you want me to take this? I'm
Sure.
going to start it off.
You can, and I can add. There are some misconceptions about medications and pharmacists, actually.
Yeah. Well,
I want to hear both.
The biggest misconception about pharmacists is all they do is count by 5s. And that it's just, pouring.
I'm sorry. I just got that.
Yeah. That's like the running joke, right? I think it was Bill Maher had made a joke that pharmacists are somewhere between a tree cutter and something else, basically saying like they don't have much role, at least in the community setting, right? I mean, pharmacists do a lot of things. So I think there's this misconception that, we talked about it earlier, it's a commodity driven business and it's just taking, bulk bottles, taking it down to size, putting it into vial and dispensing it. There's misconceptions about pharmacists, wanting to sell more expensive medications. There's misconceptions about pharmacists wanting to dispense as much as they can.
Yeah.
And, Diana talked about deprescribing earlier. I think those are the more sort of misconceptions that I've seen. And there is this misunderstanding that, we're not as knowledgeable about disease states as much as, let's say, physicians are, which our job is not to diagnose. But I don't think the wealth of information that's taught at pharmacy school, such as MAN, is something that people understand, that we're not only learning what the medications are and what they're for, but also how they impact the body and how they can, provide outcomes for patients and how they can cause drug interactions, et cetera, and side effects. So I think this idea of what a pharmacist can do and cannot do is the biggest misconception.
Yeah.
And it's not just counting by 5s. And there's a lot of information that we need to retain and understand. That's what if we call a misconception something that offends someone, those would be the things that would, quote unquote, offend me the most, right? And then the last one, which I hear more times than I care to, why can't they get the medications out faster? And I'm like thinking,
it's like, do you want the right medication?
I mean, do you this isn't, can I have a hamburger with cheese, without cheese, right? And that's the joke that we always say. And a lot of times we just can't get it out faster because we have to do all these reviews and things that we have to look at. But if they only knew the amount of work that was being done in the back end, then they might not be so considerate. And then I always say to them when they ask me that question, do you want me to get something out as fast as possible, which possibly if you put in your mouth and you swallow it and it goes into your body, it could potentially kill you? How fast do you want me to go on something that can severely harm you? Would you rather I do that, or would you rather I take my time and give you the right thing at the right time? And do it
right,
Right? So that misconception of can't you get it out any faster? You're just counting by 5. That upsets me the most.
Yeah.
And there's a lot more to it that we do.
What I want to add to this, and this is a really good point, is that misconception kind of was born out of the person who does like talk about, big box chains is here. So I'm just going to be the one saying it again. It was born out of the idea that, the bigger pharmacies came in, we're bigger, we're better, we're faster, we're going to get all your meds out in 5 minutes, okay? The drive-through. When I first witnessed the first drive-through pharmacy, it was like pouring boiling water over my head. I was like, why do we need drive-through pharmacies?
We don't.
Okay? I understand that some people don't want to go into the pharmacy, but they should want to go into the pharmacy because it's like going through a drive-through physician. Let me just put a physician in a drive-through window and then I'll just take the stethoscope and listen to your heart. It's that same concept. So I don't like these things. I don't encourage these things. I discourage patients from really going for faster, better. When you go to a nice restaurant and you want your steak, and they bring it, cooked not to your satisfaction, you send it back, right? So imagine this is your health. The most important asset that you will ever have is your health. So that misconception actually, unfortunately, was brought on by chain pharmacies. Okay, it's just the unfortunate reality. We actually, just like we deprescribe, we also try to educate our patients that faster is not necessarily better. So a lot of times, my interns, my technicians will go and say, look, your prescription, I had to just be on the phone for 10, 15 minutes with your insurance company because the way you're supposed to take it, the way your doctor prescribed and the way we agree should be taken, your insurance doesn't agree with. So now we're dealing with this third person, the third party, and we're telling them why you should be taking it this way. It is our job to make sure that you take it correctly. We get paid for that medication. So that's one of the misconceptions. But it won't be a misconception if all of us actually, even, on a different scale, from small pharmacy to big pharmacies, pharmacists, not necessarily pharmacies, talk to their patients, a lot of times people will, there are a lot of memes and a lot of jokes online, right? About chains and how people are yelling. Well, why are people yelling? A pharmacist needs to come out and talk to them and explain them exactly the entire process from A to Z. Another misconception is the pills. There's one pill that's going to fix everything.
Okay? The wonder pill. It doesn't exist.
The wonder pill. So, I took this for a week. It didn't work. They come to us. Well, you should be taking this for 12 weeks. It doesn't work in 1 week. Well, no, I want it to work in 1 week. So again, it goes back. The key is to education and finding your pharmacist. I tell my patients, find your pharmacist. That's
a good
just
point.
The bottom line.
Yeah, that's a good point. I have to admit, though, that before I knew what the exact scope of a pharmacist was, I was kind of that patient in line, like, come on, like, hurry up. But then now that it's like all these things are going on the back end to ensure that the medication I'm dispensing is the one that you should be taking. And so, like, I feel like if we knew more of that, we'd kind of give our pharmacists behind the back a little bit of a break.
And you know what's funny is that in 2024, the life expectancy is 80 years, 78 years, whatever it may be. I think a lot of people say, healthcare has advanced tremendously. It's true, healthcare has advanced tremendously. But the one big reason why people stay alive a lot longer is meds.
Yeah,
there's a lot of conditions that 30, 40, 50 years ago or 60, 80, whatever years ago, a person would die from at 45, 50.
Yeah.
But the reason they stay alive a lot longer is maybe you get early detection on disease. But what treats the disease? 90% of things that we dispense every day, maybe more, is not curative. right?
Mm-hmm.
The only things that are curative that we dispense are antibiotics,
Yeah.
pretty much.
Mm-hmm.
Everything else is just treating a disease chronically.
Yep.
And hopefully you're getting the right meds to the right patient at the right time.
Mhm.
And if they take it correctly,
Mm-hmm.
that's the other thing that we need to educate as well as community pharmacists. Make sure you take your meds the way they're supposed to be taken. As a patient, I should know. But as long as they're doing it, they stay alive a lot longer, and the doctor manages their care. And guess what? If you go to the right pharmacist, or if you find your pharmacist, that pharmacist manages your meds.
Yeah.
And together, that team helps you live a longer, healthier, or healthy life.
Yeah.
Mhm.
And that's the conception that people need to have of what it means to get healthcare. And that's why I would want to walk into a community pharmacy, because it's a serious part of the healthcare that you're getting, not
Mhm.
just because the doctor wrote it, but understand what those meds are. People are so careful about things that they put on their skin,
Yeah.
but then you're putting something into your body that, first of all, will never leave your body,
Mm-hmm.
Mhm.
and understand that it's important how you take it, the right thing, and learn about it.
Yeah, I need my father to listen to just this blurb of this episode podcast so that he can find his own pharmacist.
Is that the only good thing we said so far?
I think so. No, I'm only kidding. But no, seriously, because I mean, it's so important. And I've never heard it put that way, that you should find your own pharmacist in the same way that you find your doctor. Because I mean, like, you're not going to the car dealership and the first car you see is the car that you're going to buy. You usually shop around. And then, like, you thought about the restaurant, and I pictured your waiter. You place your order, and the waiter comes out with your steak, and it's raw. It's not cooked, but you wanted it fast. Like, that's essentially like what you're getting. So I kind of think I'm gonna steal that from you, Dr. Arouchanova. I think
Go for it.
Yeah, you need to find your pharmacist in the same way that you would vet everything else that's important for you. So let's talk about the future of pharmacy. We talked about misconceptions. We talked about where we are right now. We talked about some of the things that we may want to see. In 5 to 10 years, what do we see a pharmacist looking like? What do we see our community pharmacists looking like?
I'll start on this one.
Okay.
So things that are happening today in pharmacy practice in general, affecting community pharmacy more than any other branches of the practice, were things that I was talking about 10 years ago. Some of my pharmacists that are working with me right now were my students 10, 12, 15 years ago. Many of them are my residents. So it's now every time we get together, they say, well, one of them will say, you said this 10 years ago and it's happening now. And you said it was going to happen, and it did happen. I do not like when, sometimes the students will come and do appy rotations with me and they'll be like, I was at Walgreens and the pharmacist told me I can't spend that much time talking to the patient about their heart disease, right? Well, with us is you are going to spend twice as much with the patient because that pill is a commodity. I always tell my patients, the bottle that we dispense to you is a commodity. You can get it anywhere you want, including Amazon Pharmacy.
Yeah.
But the reason why you get better with the pills that you pick up from us is because of our love, care, and service that we add into that bottle. There's a secret formula that comes with it. Right? So that's where the future of pharmacy is going.
Yeah. You said that like the love and the care, it almost made me think of like your Nana or your grandmother when she's like, what makes this pie so good?
Yeah.
It's because I baked it with love. It's kind of like one of those things. Yeah.
And it is true. It really is true. When
Makes a difference.
When patients find the comfort, they heal better. It's like you said
true.
earlier, it's a holistic approach. And, it's important to bring that into their care.
Yeah.
I think it's, we've been talking about the future of pharmacy for a long time. I think from the time when we were in school about the pharmacist as a provider. It's been a long time coming, but I think now insurance companies, governmental entities, and sort of the pharmacists themselves are starting to accept that we are in a way healthcare providers. I think the community pharmacy will be a destination for healthcare for patients. We're steering in that direction. We're going that way. I don't think we're there yet. There's a lot of work that needs to be done. But California, for example, recognizes pharmacists as healthcare providers. Medicare does. And a lot of those things are going to bring about the changes. What's critical is that pharmacists themselves accept that's what they are. I think there's this hesitation on the part of,
Everybody else.
other pharmacists, right? But pharmacists if you have to self-identify as a healthcare provider
I'm
and
saying
start
yes.
acting like one
Mm-hmm.
and providing the service, and you know, I hate to bring finances into it, but you get to have to be reimbursed for those services.
Mhm.
And you know, for a long time, community pharmacies have been endangered. They've been dwindling in size because of reimbursement and PBM pressures, etc. Not to go into that topic, but I'm hoping sort of with the turn that pharmacists can provide services in their pharmacies, that's going to be enough to warrant the continuation of a pharmacy, and that we don't have sort of this number going down of community pharmacies, because I think they are an important place.
Yeah.
But it's going to take, what's going to be critical is pharmacists that are in your generation to stand up and say, I am a healthcare provider as a pharmacist,
Yeah.
and these are the things that I can do, and these are the things that I will do. So that's going to be the difference.
I think that's all. I mean, having that mentality, I feel like also changes how you treat your patients too. Like if you think that you're just a pharmacist, but not necessarily a healthcare provider, you're probably just, your role is counting by fives. Whereas if you have that mentality that you are a healthcare provider, which I think is so great that USC is doing early on, is that they've already instilled in us, like, you're not just a pharmacist, you are a healthcare provider. Like, don't be afraid to make these big decisions if it makes a positive outcome for your patients. I'm a healthcare provider.
I'll give you a great example, and sorry to cut you off, but
No.
changes like this come about slowly. Unfortunately, they're not at the snap of a finger. So here's a great example of the way that things have shifted. When Diana graduated, I didn't learn immunizations. I had to take like a separate class and
Oh, wow.
learn to give immunizations.
I think
So that was,
our class was the first one.
yeah,
You're
they
right.
were the first class.
Mhm.
But fast forward 21 years later, nowadays, if you ask somebody, where do I go to get a flu shot? The first immediate reaction is, I have to go to a pharmacy.
Pharmacy.
During COVID, which was a significant event in our history, pharmacists stepped up
Huge.
and they changed the narrative of who they are to being a destination for COVID testing. And of course, a mega effort for COVID vaccines. This is what I do here. It's one of the things we do. Come and get your flu shot, get your COVID shot.
Yeah.
But the change happened. And that's what I mean when I say we're going to become healthcare providers. It's going to take a long time for people to change the mentality and for the community to accept that, oh, I can go to a pharmacist and ask these questions and get healthcare.
Yeah.
So it takes time.
And you know, that mentality can only change if we break away from I work for someone and I do what they tell me type of a mentality too.
True.
So that mentality, again, was born out of faster, bigger, just pill popping kind of culture, which I think is changing. A lot of people didn't want to say, I am the healthcare provider, because they got up every morning, they went and they worked at a drive-through window, and their job was to, you know, dispense those bottles.
So you
they
don't
didn't
feel-
feel
yeah.
that they were actually contributing to the society, to the community. You know, I never did that because, you know, from day number one here at USC, and then later on, I knew I wanted to be present in that community. I mean, besides practicing pharmacy, I do a lot of community services. I work with Department of Public Health. We provide, you know, in-home services with patients. We drive to their homes. We hold health fairs. So there's so much you can do. And you just need to feel that way, that you are part of a bigger picture.
Yeah, yeah. We talk. Well, speaking of health advocacy, what furthering what you said about going to health fairs and doing the inpatient going to the patient houses, what can community pharmacists do to continue that health advocacy?
There's a lot of things that pharmacists actually can and do today. One of the things, and this is an interesting example. So a couple of years ago, I actually started a high school program with my children's school, where, you know, Raffi's children also attend. And the last year was our first year where we graduated the first. It's an internship program where incoming 12th graders sign up. It's a paid internship program.
Oh,
They
cool.
come, they have to complete 240 hours. And then I remember towards the end, when we were doing our community outreaches, we had multiple health clinics scheduled where we were going to provide health screenings to uninsured patient population, as well as vaccinations. I remember one of the students who came with us that weekend, she pulled me to the side after a couple of hours and she said, Dr. Arouchanova, why do these people not go to their doctors? Why are we testing their sugar levels, testing their blood pressure? And why are we doing this? So I said, let's finish the health fair and I'll, educate you on this. So, and then we decided to have an in-service with, students and educate them that these people don't have a primary care doctor.
Yeah.
They don't have health insurance. It was a shock to a high schooler that there is a person or group of people or a community that does not have health insurance. And we were the ones helping them, providing them the care that they could not get elsewhere.
Yeah.
So there's a lot of stuff pharmacists can do, especially community pharmacists are really like the front runners. And there are so many innovative things that they can do. Of course, again, this is probably a topic for another podcast. The payments and everything else is another issue because, while we do a lot of things for free, we can't do a lot of things for free. So there has to be a reimbursement. But when you do enough and you're able, and that's what I did, when you do enough and you document and you present data, some health plans come and say, look, what you just said can save us millions of dollars.
Yeah.
So we are going to pay you for your services.
Absolutely.
And that's exactly what we should all be looking into, your generation of pharmacists, and really working towards that goal.
Yeah, I think that's so important. And I'm hoping that the audience, like the current USC students or even the incoming USC students, I know a lot of times when we talk about, what do we want to do? Everyone's like, institutional. They want to do a hospital. I've been hearing a lot that people want to do pharma. Yeah. And it's like, we still need people to work in the community pharmacy. But I also got to say, though, it takes a special kind of person, a special kind of pharmacist to work in a community setting. Because you guys, if you guys were my pharmacist, I would know that I would be in good hands.
It's a daunting responsibility to be a pharmacist, right? And you have a lot of things coming at you. You're verifying 300 prescriptions. You've got 25, 30, 40 immunizations to do. You've got doctors calling. You've got patients saying, hey, where's my pills? I've been waiting for all this time. It's a high stress environment. And I'm not trying to discourage someone from doing it. But if you have that motivation and if you sort of look back as to why you wanted to be a pharmacist in the first place, I think a lot of people excel and thrive in that.
Yeah.
I always found it exhilarating to have all that pressure at once and to do everything the right way. And still, when the patient walks in the pharmacy, say, hey, John, how are you doing?
Yeah.
Nice to see you. And that made them feel special. That's the care and love that we're talking about.
Yeah.
So I understand it when someone gives the cold shoulder. I mean, I can't do it that way. That's not the way I practice pharmacy. I could see it, but I think there is, I could see it. We'll just put it that way.
Yeah. I mean, and now I'm a little bit more sympathetic because we're human. Like no one's going to have a perfect day every day.
Right.
So who knows what that situation or whatever it was they were going through at that time that made them or made me feel that way. You know what I mean? But again, I just think you probably need to get back to basics and like you said, and figure out why am I here? What am I doing?
Those same people are in a position to make the change though.
If they change their attitude.
If they change their attitudes, because, honestly, I don't think one pharmacist should be verifying 300 prescriptions or giving 40 shots and having some corporate
back to your
email.
Friends CVS and Walgreens.
Yeah, back to the old CVS and Walgreens, right? There shouldn't be this corporate type of mentality. Healthcare is not a corporate model. Healthcare is all about patients. It's all about their outcomes because when people do better, that's how we cut costs.
Well, I just wanted to thank you guys for being here. I love talking to you guys. You guys are awesome. For the incoming students and prospective students and students that are currently here, these will probably be your professors in the future. So, get to know them, talk to them. They're a great resource. And thank you, Dr. Arouchanova and Dr. Svadjian for being here and talking with us today.
Thank you. Thanks for having us.
Thank you for having us. Thank you.